All right, so this is Community Medicine Part 1. Oh, you got it. Good. Phew, tough crowd. All right, so we're going to talk about prevention, a little bit about population care, and some miscellaneous things that didn't fit in elsewhere at the end. So we're going to be talking about prevention at the patient level. We're not going to be talking about, clean water. Vaccination programs are sort of population-based. I've got that in another section. It's on the individual basis, not necessarily on a global basis about clean air, clean water, don't drink where you poop, that kind of stuff. So I do want to mention, though, the task force. I love the task force. So the U.S. Preventative Service Task Force was started in the best era, 1984. It was established. And I love it because they're a bunch of EBM nerds like me. They're volunteers. They don't have conflicts of interest. And they go in there and they evaluate the evidence on the basis of the evidence to make recommendations for whether or not screening should be done. So they have different levels of recommendation, and you should be familiar with these things. They go A, B, C, D, I. All right? Does anybody know what the I stands for? It stands for I don't know. It officially stands for insufficient evidence, but I remember it as, I don't know, what do we do with that? Right? We don't have enough information to make a recommendation, basically. And we'll go through the different recommendation levels. Now, the task force, when they're talking about recommendation, they don't consider cost, and that needs to be explained. When it comes to looking at the evidence, cost is irrelevant on whether or not the screening works, right? Whether there's sufficient evidence to say it works. Cost and application and implementation of a screening program is more of a society's question or a government's question or a health system question on should we be doing this based on how much it costs. But whether or not it works is irrelevant to the task force. All right. And it's only for asymptomatic people, I should say that. So this is not for the woman that finds a lump in her breast. This is not screening recommendation, right? That you've got a sign or a symptom, you don't fall into the task force, right? If you're getting up 10 times a night to go to the washroom, we're not talking about screening for a large prostate anymore. You're symptomatic. So this is for asymptomatic patients in your office or people that are asymptomatic in your office that you're referring for a colonoscopy or something like that as colon cancer screening. And there are the recommendations. I recommend it this way. That's a grade A recommendation. Hey, you better do that. Okay? B is, yeah, you better do that. C is, consider doing that. I'm not sure, but consider doing that. Like, have a discussion with the patient about that. And D is, don't do that. There's probably more harm with that recommendation, so don't do that. So that's the A, B, C, D. And then, of course, the I is, I don't know what to do with the information. We can't make a recommendation either for or against. So it's not like it's neutral. It's not like it's consider doing it. It's, we don't know. We don't have enough information. Here's a little hint. Sorry, I got something in my eye. Sorry, I should do it on this side too. These might be great ways for examiners to mine the A and B recommendations for questions on an exam. They think that you should know the A and B oh, there it is again. Something in my eye. You might have a question from the task force, A and B recommendations. Been obvious enough? So we have put the link in there for you, so we would strongly encourage you to review the A and B recommendations prior to the examination. Now, you've probably all faced this. The age discrimination, when you need to stop screening, because screening is no longer recommended. And I've been, in medicine long enough to have had patients that go, yeah, I'm here for my yearly. And I speak woman, okay? And that means I'm here for my yearly Pap test. And you start telling them, Mrs. Jones, you don't have a uterus. You don't need a Pap test anymore. And it takes away from that therapeutic alliance if you don't explain it correctly. If you start throwing out, well, listen, I don't think you're going to live long enough to benefit from this screening. That typically doesn't go over well. I don't see 5 years on your horizon. So you really have to be compassionate and careful with how you stop screening, because we're talking about screening here, but how you stop screening and say, listen, there is this screening recommendation, but it's not going to make you live a longer and healthier life, and that's what I want for you. I want you to live as long as possible, but as healthy as possible, and this screening won't do that. So it's how you frame it. And then we're going to move on to, from screening here, this is about prevention on an individual level. So preventing disease, not screening for disease, preventing disease. And I mean, it is really hard to change people's behavior. I mean, it's one thing to like sort of herd cats, i.e. doctors, right? It's one thing to change behavior for physicians, but changing patients' behaviors, we have whole industries set up to try to change people's behavior with regards to their weight, with regards to smoking cessation, all sorts of things. There's huge billion-dollar industries set up to do it because it's hard to change people's behavior. So we're going to talk about strategies that can do that you may be asked about on the exam. So first of all, you want to match your approach to the patient's position. Where are they? Are they pre-contemplative? Are they contemplative? Or are they ready for action? Tell them why it's important, but look for small changes, baby steps, early victories, early wins to bring them into that changed set of mind so that they want to make a change. But it has to be like sort of a successful, small change to get them started often. And be specific. Don't go, hey, I think you should be healthier. It's just too nebulous, right? How about you give them a specific thing like, hey, maybe you should get out, consider getting out and going for a walk after dinner 3 times a week. You know, just to get the digestion going, go for a nice walk after dinner. Be specific about what you're asking them to do. And add a new positive behavior that rather than trying to take away a negative behavior. So, you know, sort of, you know, if you're snacking, how about some carrot sticks or celery sticks? You know, so add a positive behavior as opposed to, I think you big fat slob should stop eating potato chips. It doesn't go over as well for changing behavior. So try to add something positive rather than eliminate something negative. And adding that positive thing like snacks that are healthy snacks can displace the unhealthy snacking. And link it to their daily routine. If you're going to work every day, park at the farthest parking spot, not the closest parking spot. Gamify it and say, why don't you park at the farthest parking spot and walk up? Why don't you take the stairs instead of the elevator? Attach it to a behavior or a habit that they're already doing. And get a promise out of them. You need to see, yes, are you going to do this? Like, you know, get them to commit if possible. And it usually takes a combination of strategy. So I refer to it as the mixed martial arts of patient behavioral change. So, you know, you got to do jiu-jitsu, taekwondo, Karen technique. Does anybody know where this is from? Thank you. Somebody's got to yell it out. The Karate Kid. Wax on, wax off. Paint fence. Right? And so you've got to use mixed martial arts when you're trying to mixed combinations of programs to try to get them. And, you know, you can't do everything. You're expected to do everything. But, you know, get some outside help to help you do that. And stay interested in their journey. So, from that, we're going to talk, this slide is leading into smoking cessation. So we had to put it somewhere. This is about air pollution. Dirty, dusty air is bad for people, okay? It can cause badness. And there's air quality indexes that you get from green down to brown at the bottom, and that talks about particle matter in the air. And you've probably heard this on the radio or television when they're giving news reports at certain times of the year, what the air quality index is. And this is from the EPA. But this is getting into a specific air quality, an individual patient air quality thing. I don't think lighting something on fire 25 times a day and breathing in smoke is probably good for your lungs. Now, if you go back to the 1960s, right, you'll see great old ads in black and white of that old senior male physician with the cigarette going, I prefer this brand because it's smooth and it helps me breathe and stuff like that. Oh, how the world has changed. But that took 50 or 60 years. I think this vaping thing is going to happen quicker, right? But the smoking thing. So if there's one thing you could do for your patients in your practice today, it would be to get them to quit smoking, to encourage them, to help them on that journey to quit smoking. It has a huge impact on their overall health. But it's hard. If it was easy, everybody could do it. Nicotine is highly addictive. Highly addictive. And if you stop, it's not like alcohol where, you know, you have that patient that you're doing hospitalist for the week or something like that, which I do 1 week every 6. And, you know, 2 to 3 days in, Mr. Jones starts going squirrely. And you think, oh, maybe he's a drinker, right? This happens within hours of not getting a nicotine hit. And people are irritable and miserable. But a lot of the things that we're worried about is that last thing where they say, I'm worried about how much weight I'm going to gain from stopping smoking. So you go through the pre-contemplative, contemplative, and into action. In the pre-contemplative, you ask the same question, do you want to quit smoking? Can I help you? Is there anything you need to know about that? And if they say no, right? Okay, yeah, acknowledge and move on. It's like mindfulness. Acknowledge, move on. You acknowledge it, but you're not going to give up. You'll keep repeating it at each office visit. Now, if they say, well, not now, it's like, oh, you've just opened the door. Ken's coming in, and I'm going to talk to you a little bit about, you 50% less chance of having a heart attack in the next year. I think you should consider it, right? And then you're into the action stage, and that's where I'm like, oh, yeah, you want to do it? Okay, let's set up a program. Let's do this. And then the 5 A's and the 5 R's. So you can ask, advise, assess, assist, and arrange follow-up. Those are the A's. And then there's the 5 R's, the pirate version, the R's. There's the relevance, the risk, reward, roadblocks, and repetition. And repetition and repetition, okay? Because it's hard, and there will be fallbacks. Even a brief little minute of intervention has been shown to double your risk, double the chance of success of people quitting smoking. Now, that's a little misleading, right? And I'm an EBM guy, so that's probably a relative risk as opposed to an absolute difference, right? It doesn't go from, somebody wants to change. It goes, if you say something for a minute, it doesn't go from 25% to 50%, right? That's a 25% absolute. The number's probably like, 1% chance to a 2% chance, right? But that doubling, that small doubling, can be significant for that one individual. All right? So what really makes people quit? Price. People are cost sensitive. The more expensive it is, the less likely they are to continue to smoke. Also, having a smoke-free work environment, I think this works in northern climates more than southern climates. So if you could just walk outside and smoke and it's comfortable, okay. But if you're in Minnesota, did I insult anybody there with my Minnesota accent? If you're in Minnesota and you have to trudge through this winter is coming, right? If you have to go through that just to have a cigarette in your work environment, you may be more likely to quit. All right, having access to health professionals that can help you, access to treatment programs, whether they're pharmacologic, whether they're patches, whether they're behavioral, all of these things, having access can increase your chance of success. This slide, of course, was made before e-cigarettes and all of that started hitting with vaping-related lung injuries. Like I said, I think we're going to learn quicker about this vaping issue, but the task force at the time gave it an I recommendation. In other words, they didn't have enough information to make a recommendation one way or the other, whereas the American Heart Association says it has to be a bridge to somewhere. So if you're using vaping, if you're using e-cigarettes to quit smoking, okay, it's a bridge to somewhere, but it can't be a substitution. I'm going to go from cigarettes to e-cigarettes, all right? That is substituting one bad habit for another bad habit with health consequences. And they say it has to be a bridge to somewhere. Now, smoking's hard. Let's get down to something that's much easier to deal with, opioid. No, you guys don't have any problems with that, do you? No. Okay, so preventing opioid abuse, certainly using non-pharmacological agents, great. Using opioids only if the expected benefit exceeds the expected harm, and use it in combination with other therapeutic modalities to try to prevent this opioid abuse syndrome. Before starting it, for chronic pain, you should establish some treatment goals and consider what would happen if you stopped the opioid to try to prevent it, and use immediate release, not using the long release, and start low and go slow if you're going to put your foot in the water for this. But I think you guys are getting lots of education now with regards to opioids. And then reevaluate the patient for their chronic pain in a reasonable time frame within the next few weeks to see how it's going with opioid to try to prevent that abuse from happening. And then look for risk factors. If you have a an addictive personality and you've been treating this person for alcohol addiction, putting them on long-acting opioids may not be the best therapeutic modality. And then we've got databases, and I'm not a big fan of electronic health records, but having a database where I can look and find out and see what's going on with regards to prescriptions, that can be helpful at times. I'm not as thrilled about doing urine tests. That'll be up to the individual. I don't want to feel like their parole officer. I want to feel like their physician, their clinician, their advocate, and urine drug testing, but it is required in some areas, so I understand that. And of course, giving other sedative agents, the risk of, giving opioids, here's your 10 of hydromorphone, right? And there's your 10 of Valium, and there's your Q sign, right? Because of respiratory distress. So you need to be careful about that, obviously. And then if they do express that they are having opioid-dependent problem, this is a medical issue, all right? And we need to be there for our patients and help them and refer them to the appropriate resources if you are not able to provide that service so they can get the help they need. All right, health literacy. This is another sort of in that community medicine section. And we've got to understand, you guys are very, very smart. I mean, you may not feel very smart because you have this big manual and like, oh, wow, I didn't know that. I've been doing this for 10 years. I've been giving out Macrobid for 3 days or nitrofurantoin for 3 days instead of 5 days for UTIs. Ooh, I wonder how long that's been going on, right? You may not, but you are elite. You are very smart, but your patients have not had the same level of education and opportunities that you may have had, right? And so we need to recognize that with regards to health literacy. So we recommend the teach-back method, and that's where you give the information and you ask the patient to parrot it back. So you don't say, hey, did you get any of that? Do you understand? It has to be framed in I just want to make sure that I'm making sense. Do you understand what I'm saying? I'm trying to get this important message. Do you mind just telling me back what you heard so I know if it's really getting through, if I'm doing a good job of communicating? So put it on yourself. And that's the teach-back method. And it's been shown that can help. Now, it doesn't help a 30-day rehospitalization rate, but it can help in other areas. And then limit your information to 3 things. Because once you get up past 3, people don't retain as much. If anybody's been in to have their car fixed, right, or have their computer looked at, you're not an expert in those areas. And how does that make you feel, right? Some of you might have advanced degrees. You might have PhDs, and you're in there, and the mechanic's telling you about the timing belt, and you're like, right? And you don't want to feel like an idiot, right? And they're not idiots. It's just amount of education and health literacy. Patients with disabilities. So people with disabilities, usually they complain that the physician or clinician focuses more on their disability as opposed to their abilities, and they're a person beyond defining them as just their disability. So prevention and screening and all of those things still need to be applied to those individuals, and a focus on that as well, and not just get so lost in their disability. There are certain barriers to access with regards to care, with regards to transportation, provider knowledge, specific coordination with other healthcare providers, and certain negative attitudes towards disabilities. And this is not sort of meant to follow, gay, lesbian, bisexual, transgender is not a disability, okay? That is not a progression from that slide. But there's certainly biases within medicine and within the House of Medicine also against these individuals, and they can be vulnerable, especially with mental health stuff and suicide and violence and stuff like that. So we need to be sensitized to that. All right, so let's get from there to a question. I don't know if Gary had any questions in his talk, but I have a few questions scattered throughout mine. This is to prove medical negligence. Which statement is correct? What is it? Is it the physician charged more? Is it about money negligence? Is it about you failed to diagnose a rare condition? Is it they did not meet the highest standards, or the failure caused the patient harm? What's the answer? Thank you. Oh my God, that was a long pause. I don't know, I'm going to get you a prize or get you a coffee or something. Thanks. Appreciate that, man. Whew. Yeah, just shout it out, okay? So, it's not about cost. You don't have to make rare diagnoses. That's not the expectation. The reason they're rare is because they're rare, and it's not the highest standard for negligence. It's the standard, not the highest standard, the standard of care. All right, medical negligence. There's 4 components to it. You have the duty to provide the care. It was your responsibility to provide that care, and that you breached that care at a minimal level. What's the minimal standard of care? And you fell below that, that the person suffered harm because of that, and then the harm was caused, it loops back to your failure to provide the appropriate minimal care, medical negligence. Ethics, this is about informed consent, and I think you guys know that to do a procedure or do some kind of treatment or therapeutic modality, giving blood transfusions, things like that you might be involved with, you have to give informed consent, and informed consent means you have to talk about the potential risks and the potential benefits to the intervention, and then make sure that person is able to understand and verbalize that or be able to write back that they acknowledge that they understood that and that their questions were answered. Decision-making capacity, so we do that all the time and say, yep, no, they understood. But there's a difference between making a decision about their ability to understand and their capacity to being told that they're incompetent. And competency falls onto the legal system, not onto the medical system, with regards to minimal mental, cognitive, and behavioral ability. And that's a legal responsibility as opposed to a medical or clinical one. All right, now we're just going to go through some genetic stuff. This is a little bit of grab bag stuff at the end. When is genetic testing recommended? Well, if you've got carrier testing, so it runs in the family, or you're doing pre-implantation stuff, so if there's Huntington's in the family and you're going to do in vitro fertilization and you're going to be harvesting eggs, you'll check the oocytes, depending on how you pronounce it, for genetic conditions prior to implantation. Prenatal diagnoses, we do that all the time, looking for trisomies. Newborn screening to detect genetic disorders, which treatment may be available, because there's no reason, if you don't detect something and there's nothing we can do about it, why detect it? And preventative testing, the probability that you might have something based on your genetics. And specifically BRCA testing. Now BRCA testing, we're going to go through this later in the course, so this is just an overview about BRCA testing. But women with a family history of breast, obvious. But also ovarian, tubal, or peritoneal cancers should be considered and screened. And you apply a screening tool. And if the screening tool is positive, then you have them see genetic counseling first before you actually do the genetic testing. Okay? And so you don't want to get that order reversed and send someone for the genetic testing and then have to work backwards. Screen, if they screen positive, get them the genetic counseling, and then do the genetic testing if they want to still do it. Now, if possible, test family members with cancer. So if the family member is BRCA negative, the patient doesn't need to be tested. But if they're BRCA positive, you can test for that family's mutation only, so it's less expensive, so you don't have to do a whole genome test, which they don't do, but it's less expensive if they already know that they have one of the BRCAs. But it's not recommended for women whose family history is not associated with an increased risk of a bad mutation of BRCA1 or 2. But like I said, you're going to get more on that. So that's just a quick overview. There'll be spaced repetition with regards to that. And then filling out a death certificate. There's wide variation with filling out death certificates, and it can be complicated. You're supposed to put the immediate cause of death. Now, everybody dies of cardiorespiratory arrest, right? Your heart stops beating and you stop breathing, right? But that's not specifically what they're looking for the immediate cause of death. That's the final common pathway to death, right? Your heart stops beating, you stop breathing. What was the intervening causes? And what was the underlying causes? And what were the contributing factors? And that can get really complicated. So I have an example to make it easier to understand. So an elderly woman is in a nursing home. Because she's hemiplegic from a stroke, she dies of E. coli sepsis subsequent to a urinary tract infection, and then she had a Foley catheter placed 6 months prior to that. What's the immediate cause of death? What caused her death? The immediate cause, she went to sepsis because she had E. coli. She had E. coli, urinary tract infection, sepsis, and death. What contributed to that? Sepsis? Well, it was a UTI, and she had a catheter. What was the underlying cause? Well, if she hadn't had the stroke and be institutionalized and paraplegic, she wouldn't need the catheter. So the underlying cause. So hopefully that, reviewing that can help you if they ask you any questions about filling out death certificates on the exam. And then a little bit about international travel health. So I love the first bullet point here because this is totally not how it happens, right? How does travel and immunization and international travel health work? I'll give you an example. Hi, I need to see Dr. Milne. I'm going on a trip. Oh, when are you leaving? Tomorrow. Right? Isn't that? And it's like, are you kidding me? And what time is it? 3 o'clock in the afternoon or something like that. It's like they need to come in and review all this before they leave for somewhere. Yeah. So you're supposed to give a lead time of 6 weeks. All right, so you can get people prepared for their international travel. And important information is like, when are they going? Hopefully it's not tomorrow. Where are they going? Which different countries, because they might be on a whirlwind tour or something like that. Talking about a budget for health expenses while they're gone, right? Different countries have different insurance and access to care and those types of things. So I like this, though, the most common cause of travel-related death in the non-elderly. So, like the wonderful old couple that's going on their 50th wedding anniversary cruise, we understand that they may die from various things, usually heart-related, right? But the number one cause of non-elderly death is motor vehicle collisions. Totally get that. I took my 3 young kids and my wife, and we went to Australia. Okay, so you're in a different country. You're driving on the wrong side of the road. You got 3 kids, little kids behind you, and your wife telling you how to drive beside you. This is a recipe for mortality, right? So I totally get why that would be the leading cause. So if you get the question, what's the leading cause of non-elderly death in travel? It's think of me driving in Australia going, oh my God, the cars are, I'm on the wrong side, right? So that is why. Prevention, all right, so insect repellents and stuff like that, looking for, mosquito-related or insect-related disease conditions, and diseases that have routine immunizations for it. We should be immunizing our patients for that and update all their usual routine, but there's country-specific immunizations that can be recommended. And so there are the routine stuff that's there. And what I do is I just go to the website. I go to the CDC website, and they've got a nice map, and you click on the map, and it shows, they're going there. This is what they should be concerned about. This is what they should be immunized against. Thank you. It's a great resource. It's constantly updated, and I don't need to remember it. And so I use that CDC website. The World Health Organization also has one as well, but I don't use that one. Traveler's diarrhea. This is the most common illness a person gets when traveling. So if you get that question, that's the answer. You get the runs. All right. Now it's usually from developed countries going to resource-poor countries. That's how it usually goes because of various things with regards to sanitation, water supply, and different bugs. It's defined as having 3 or more loose stools over a 24-hour period, plus either fever, nausea, cramping, or vomiting. So yes, you can have diarrhea, but that's not traveler-induced diarrhea. 3 loose stools minimum, but you also have to have some of the other signs and symptoms of that. So having a fever, having vomiting, cramping, stuff like that. It usually just runs its course, but within 3 to 5 days, it's gone. And the number one bacteria is the number one cause, and it's usually E. coli. So E. coli is the number one cause, and 4 to 5 times it's bacterial. Now you can have viral and you can have other pathogens associated with it, but it's usually bacterial. And if it's bacterial toxin, it usually comes on within hours. If it's bacterial, it can come on within hours to days. If it's viruses, it's usually hours to days. And then if you're getting into protozoas, you're getting into 1 to 2 week time frame. Untreated bacterial diarrhea, like I said, it usually runs its course over 3 to 5 days, roughly. All right, and anti-motility agents can be helpful for these patients. But if you get traveler's diarrhea, how do you prevent it? Preventing it, wash your hands. It's water, bottled water, wash your fruits and vegetables when you're eating abroad. Alcohol-based hand sanitizers. Prophylactic antibiotics are not recommended. You can consider high-risk people going to high-risk places for Pepto-Bismol and things like that. And the primary treatment when you're treating someone with traveler's diarrhea is just make sure they're orally rehydrating well enough. But for moderate to severe versions, you may need antibiotics. And fluoroquinolones is our usual go-to, but this has just been updated that says in Asia there's a lot of fluoroquinolone resistance, and so we're going to azithro for that. That's getting fairly granular. And then the final thing on traveler stuff is requiring oxygen therapy. Now, the FAA has some concerns about people being cylindrical objects onto a plane with explosive gases in it, so you're not allowed to do that. Try to get through security with one of those canisters. It won't happen. But if you're going to be advising patients, well, you can take a concentrator with you. And you have to dial that concentrator, that oxygen concentration up by about 2 liters when you're up at that altitude and in a plane. And so that's for our travelers. And even now, when I'm traveling and stuff like that, has anybody else noticed that it seems like this is confirmation bias, that everybody going through the airport has this little lunch box, this little thing, you know, going through the airport, and they have to unpack it going through security. You know what that is? Everybody with CPAP devices, right? I didn't see those 5 years ago, but it's really changed things going through security and seeing these people with, you know, they're the size of little lunch boxes and stuff like that now that they're miniaturized. It's been a real change with travel. All right, that's the end of Community Medicine Part 1. There will be Part 2. Thank you very much.